Hi, this is Brian Kim. I want to share with you this case of a patient who was referred to me. Her other eye has had a retinal detachment, and essentially this is her good eye. And she had a lens dislocation, which was then exchanged, was placed into sulcus, but was still dislocated afterward. And so the patient's referred to me to see if there's anything else that can be done. Every IOL dislocation case poses different challenges, and so we'll see what this case shows us here. So you can see the lens is dislocated, and you can see the anterior capsule opening there. And right there is an area of zonular dehiscence or weakness that you can see. You can see the anterior capsule opening is a little bit discentered. And so I'm a little bit mindful of this. And I wonder if, during the exchange, the capsular bag was a little bit stubborn and attached to the lens, and it caused that small area of zonular weakness. So I make my incisions first on the right side and then the left side. I'm injecting some intracameral lidocaine. And then I'm using the Sinski hook. Again, this lens is in the ciliary sulcus. So I'm using the Sinski hook to grasp the optic on the other side, and I'm tucking the optic around the anterior capsule there on each side. And I'm essentially creating an optic capture configuration here. And you saw I did this essentially with no viscoelastic or anything. I'm trying to assess how well the anterior capsule is going to be able to hold this optic. One thing I'm noticing is there's an asymmetric overlap to the anterior capsule around the optic here. And so I'm trying to figure out why that is. So I go in with the BSS cannula and just trying to tease the anterior capsule off the posterior capsule here. What I suspect is that there's a little bit of fusion of the anterior and posterior capsules on this temporal side of the capsular bag here. So I'm using BSS to kind of push and try to create a little bit of separation between the anterior posterior capsule. And I do wonder if I should have just gone ahead and pushed viscoelastic in at this time. I suppose I was trying to make this as elegant and as quick as possible, because if I put viscoelastic in, then I'd have to go and remove the viscoelastic again. So I'm trying to reposition the lens, making sure I get good overlap so that the optic is in a true optic capture configuration with the haptics and the sulcus. So I go ahead and hydrate my incisions. You can see that the lens is well centered now. I have good optic capture configuration, despite having a little bit of an asymmetric optic capture there. There's more overlap on the left side here than the right side, but I felt pretty confident that I got pretty good overlap on each side. Even though it's slightly asymmetric, I have pretty good overlap, and I do feel this is a pretty stable situation for this lens. I did tell the patient, because she did have some evidence of zonular weakness in that nasal area, that down the road she may need to have further surgery. And so she is prepared that she may need to have maybe have a Gore-Tex suturing to the sclera. But in essence, in these difficult situations, you want to essentially tell the patient, you're putting the lens in a less than an ideal situation. And so we're going to do the best we can to stabilize the lens, and hopefully it'll provide a long-term stability. So I hope this was helpful to you, and I thank you for your attention.